Uganda is facing a diabetes epidemic. Gestational diabetes is a form of diabetes mellitus that affects 1 in 10 pregnant women, and yet its serious risks to both mother and child are not widely known. Gestational diabetes mellitus, or GDM, is defined as glucose intolerance with onset or fast recognition during pregnancy. Women who are overweight, older, have previously had a large baby, and those who have a family history of diabetes are more at risk. However, many women who are diagnosed with GDM have no obvious risk factors. If undiagnosed or poorly treated, it can lead to significant health risks for the mother and child, including increased risk of developing type 2 diabetes later in life.
It is affecting mothers and babies, not only in Uganda but world over. But here is worse because we don't have the knowledge on how big the problem is. Number one still remains on encouraging our mothers to start antenatal early, to screen these mothers in the right time, between especially 24 to 28 weeks. And those who are diagnosed positive, we give them health education on diet and exercise.
Many mothers are becoming pregnant, so we have very big numbers of pregnant mothers in our society. And then 3, we have poor screening procedures. So most of these mothers even go undetected when they are pregnant. So because we have started screening, we are seeing big numbers.
Ideally, all pregnant women in Uganda should be screened for GDM at least once during pregnancy. Women should be first tested as early as possible in the first trimester, preferably at the first antenatal care visit, to rule out pre-existing diabetes. If the first test is negative, women must be tested again between 24 to 28 weeks of pregnancy. Diagnosis of GDM should be via a fasting plasma glucose test or via an oral glucose tolerance test using a 75-gram glucose load. Health facilities with lab services can use semi-auto analyzer or auto analyzer if results can be made available immediately. All other facilities are recommended to use plasma calibrated glucometer for same-day diagnosis. It is vital to have facilities for testing and a constant supply of glucometers and medicine such as metformin and insulin at all antenatal care settings. Once diagnosed with GDM, initial management should focus on lifestyle changes. This should include advice about increasing physical exercise and a carbohydrate-controlled balanced meal plan, which takes into consideration the patient's medical and dietary history and their BMI. A trained dietitian should give this advice where possible. Group education on lifestyle modification can be provided where resources are not available to offer one-to-one support.
I think a lot of people are shocked, a lot of people are sad, but learning about it and accepting it, I think, is one of the ways that they can manage to come to terms with the diagnosis.
Try to take a moment to discuss the difficulties the woman may have managing her GDM. Identifying an achievable goal related to a single behavioral change is an ideal place to start. This could be a small goal, such as walking for 15 minutes every day, or filling half the plate with vegetables for lunch and dinner. Taking small steps will build their confidence. Women must not be made to feel guilty if they fail to reach their goal, but should be encouraged to keep trying and stay positive. After around 2 weeks of following a meal and activity plan, a 2-hour postprandial blood sugar test should be carried out. If blood glucose is well controlled, for example, less than 120 milligrams per DL, the pregnant woman can continue with dietary advice and physical activity only. If the blood glucose remains high, then medical therapy is indicated. If drug therapy is indicated, prescribe either metformin or insulin as first-line treatment according to local guidelines. if blood glucose is not controlled on metformin alone, insulin can be added to the treatment program.
Initially, we are worried about metformin, but research has proved that metformin has no complication in pregnancy. So immediately, the mother, even if she's 1 month old, we start her on treatment. If the mother has like 7 millimoles per liter, we may start them on metformin, but if the levels of insulin are more than 10 millimoles, we usually start them on insulin.
Insulin should be injected into the thigh, upper arm, or abdominal wall intradermally. The woman must be trained carefully to inject herself and monitor blood sugar levels at home. Symptoms of hypoglycemia include shaky hands, sweating, trembles, headache, mood changes, irritability, and a tingling sensation around the mouth. Following a treatment program for GDM can be challenging. It can be helpful to try and involve other family members so they can support the pregnant woman. Encourage women to bring a family member or friend to appointments.
Ultrasound scan is very important in these mothers with gestational diabetes. In most cases, we do a first scan between 18 weeks and 22 weeks to look at the structure of the fetus, what we call the biometrical structure. And then we do a repeat ultrasound at around 28 to 32 weeks to look at this physical structure of the baby, of a fetus, and then we do another scan between 34 to 36 weeks. So we usually do at least 3 ultrasound scans in these mothers with diabetes. It's very important when a scan diagnoses a big baby, usually it's handed over to the obstetrician who plans the mode of delivery. And in most cases, the safest way is to deliver these mothers by cesarean section if the baby is really big.
If blood sugar is well controlled and there are no complications, women with GDM should receive antenatal care as per high-risk pregnancy protocol. Breastfeeding is recommended immediately after delivery to avoid the baby becoming hypoglycemic. All infants of mothers with GDM should be checked for hypoglycemia using a glucometer within 1 hour of delivery. Capillary blood glucose testing for infants should be conducted via heel puncture and performed by a trained health professional. Immediate postpartum care of women with GDM should be similar to women without GDM. Maternal glucose levels usually return to normal after delivery. 6 weeks after the birth, the mother must have a 75-gram OGTT. As women who suffer from gestational diabetes are more likely to suffer from type 2 diabetes in later life, it is important that they attend an annual follow-up screening. Advice about healthy lifestyle and behavior should be given at these checkups.
We are doing a lot of community education. We are over the radios. We go to the lower health units and educate the mothers in their communities, and we pass off this information. Mothers should attend antenatal care as early as possible. Then they should be screened for gestational diabetes. And we are also teaching the health workers to be very vigilant on gestational diabetes, so that every mother who comes to us should be screened for gestational diabetes, so that we don't miss these mothers. That's what we have started, and we are getting good results now.